Next, I'd like to call up here Brendon McDougall. And Brendon is the Integrated Care Projects Manager with South Eastern Sydney Local Health District. Welcome, Brendon. And Brendan's going to be telling us about the Integrated Care, the Health Coaching and Practice Program at South Eastern Sydney. So, welcome, Brendon. So the click is here, and your timer will start there.
Perfect. Thanks, Anthony. So today I'm going to share with you some work we've been doing in South East Sydney around health coaching and what we've been doing to investigate and improve the way health coaching is actually applied in clinical practice. So first of all, why are we looking at health coaching? It's a focus of the district and state integrated care initiatives. And it's documented in some of our strategic plans that we're going to work towards a coaching culture and towards providing health coaching. It's well supported by the literature to improve health, to improve well-being, to improve self-empowerment, and to improve self-management, which actually links quite well to that previous question around how do we get people to join these sorts of programs. And it's also estimated that within South East Sydney, 21% of our population has multiple morbidities, and we have an aging and growing population, a growing aging population as well. So we need to move beyond traditional care models and focus on self-management and self-empowerment. So to support this, from 2012 to 2017, health coaching training was made freely accessible to district staff and local primary healthcare providers. So in this time, 721 healthcare professionals and support staff attended training, which was provided by an external training provider. The training provided was quite comprehensive and numbered a number of different training opportunities. So on face value, this looks really good. We have a large number of healthcare providers attending a number of different training options. However, what did this actually look like in practice? So at this point, I'd like to introduce my own personal experience with health coaching. So this is me, about 7 years ago. Bit more hair, few less wrinkles, few less kilograms, but it's me. So at this stage, I was working as an exercise physiologist, providing rehabilitation services for people with cardiac and pulmonary conditions. Now, as a young exercise physiologist, I was keen to learn. I was keen to improve the way that I provide care to patients. And I was introduced to health coaching. So I went along, attended the 2-day training program, thought I knew everything I needed to know, went back to implement this and thought I was going to improve every patient's outcomes. However, when it got to the point of actually delivering it, I wasn't getting the outcomes I was anticipating, and I wasn't even able to get to where I wanted to with my coaching skills and working with patients. So what did I do after a few months of trying? I just gave up. I just went back to the normal treatment, the way I used to do things. So through talking to other healthcare providers, I quickly realised that I was not alone in this problem. Other healthcare professionals were experiencing the same thing. So 6 years later down the track, I was working in the district's integrated care unit where I am now, and an opportunity arose to look at how coaching is actually being applied in practice. So at this point, we didn't really know. There was no evaluation on how it was being applied in practice, but we knew there was opportunities for improvement through discussions with healthcare professionals. So we formed a project team with district staff and primary health network staff, and we applied redesign methodology to really understand what was happening at this point in time, which included a huge amount of work around surveys, focus groups, workshops, interviews, and data analysis. So what did we find? First of all, on the consumer aspect. So we had a number of different consumer workshops and interviews, and some of the things they were saying. So specific to one of our services providing health coaching, one consumer said, "I don't think I would still be working if I didn't come here." Another said, "I needed this 48 years ago." And many thought it would be good to involve families and carers in coaching sessions as well. And when we were surveying, 100% of patients reported needing more support post-diagnosis, which could come in the form of coaching. So what did we find when we were working with healthcare professionals? So first of all, we've surveyed 429 previous training participants who we had email addresses for. We got 149 responses back, so a pretty good return rate. And some of the good things we found: 98% of healthcare providers believe there are patient benefits to coaching, 97% believe there are healthcare provider benefits, 79% valued the effect on their work, 93% supported the use of coaching in clinical care, and 85% believe coaching was a part of their role. So this is really good. But the not so good. I'm not calling it the bad, but the not so good. So only 27% of our healthcare providers agreed there was sufficient training available. Despite all our training options, only 27% agreed. 22% agreed there were sufficient resources and support available post-training. So again, quite low. 42% agreed that management supported health coaching, so that could obviously be improved. And 37% agreed there was a shared vision of what coaching should look like and where it's going in the district. And most importantly, 54% of those 149 respondents were able to implement and provide coaching. Okay, so, and this is probably over-representative of the actual number because these are only the people who replied to the survey. So we examined what was happening and we looked at some of the barriers to coaching. So the first most reported barrier was time. So many healthcare providers perceived there was a lack of time within the daily schedule to provide coaching. Underlying reasons for this did include high patient volumes, activity-based funding models, and the perception that health coaching was an add-on to usual care. The second most common barrier was what we themed as patient attributes. So this was belief that you couldn't coach someone because of a language barrier, or because of their cognitive ability, or because they might be resistant to coaching, or have an expectation of treatment that didn't involve coaching. The third most reported barrier was support and understanding within the workplace. So it was perceived lack of support from management and colleagues, and there were no support structures in place to access subject matter experts in coaching. And the fourth most frequently reported barrier was workplace processes. So rigid and long-standing assessment and treatment protocols that were unconducive to providing health coaching, environmental settings where treatment was taking place, and within forms and templates in medical records and communication systems, they're not set up to include documentation on coaching discussions. So these four barriers alone attributed to 78% of the total barriers. So what we did from there is we further looked at those four sort of theme barriers and found what the root causes were to that. The first being that the coaching training provider was not tailored to the healthcare provider's context or their clinical area or patient type. It was too generic. There was limited promotion and knowledge of further health coaching education and learning opportunities. The health coaching training did not adequately cover how to implement training into practice. We taught them what it is, but didn't teach them how to implement it. There were no post-training support structures in place. The support and resource requirements weren't even identified to put them into place. Our health coaching was generally viewed as an add-on to clinical assessment and treatment and didn't become standard practice in a lot of cases. There was no definition even of what health coaching is within CESLID, and there isn't actually an agreed upon standard definition in literature even. The purpose and benefit of health coaching was not well promoted, and coaching methodologies being taught were viewed as rather complex, which led to a misunderstanding of what health coaching can be and how it can be applied. So we broke this down a bit further and identified three key issues. So this was prioritised based on the project's team ability to influence the issue and the likely impact that addressing it would have. So the three key issues to be addressed by the project team included the content and the structure of the health coaching training being provided, the availability of post-training support and resources, and to address the variance in knowledge and understanding of what health coaching is, how it can be applied in practice, and the potential benefits to patients, healthcare providers, and the organisation. So, following that, to address the key issues, we worked with stakeholders to identify four key solutions. So these were to develop and spread a definition of health coaching, including what health coaching is, how it can be used, and its likely benefits. We wanted to improve our training and support models. We wanted to provide online health coaching resources to participants of the coaching programs, and we needed to develop an ongoing evaluation framework. So initially we started to work on all these four solutions individually, but we decided to wrap them up into one program, which became known as Coaching for Better Health Outcomes. So in developing this program, firstly we had to decide, were we going to keep using the external training providers, or were we going to try and design an internal program? So we consulted the literature and what our diagnostic work showed, and participants of training programs wanted an internal program, and the literature shows that clinical skills are hard to translate, but soft skills like coaching are even harder to translate again. And it's proposed within literature that the best return on investment for time spent developing coaching skills is achieved when programs are developed in-house with an understanding of the local context, support from management and leadership, and ongoing professional support through the provision of coaching supervision. So after that, we linked with our district's organisational development and learning unit, where we funded a dedicated project officer position, which was filled by an internal applicant with executive and organisational coaching skills and qualifications. So we then went on to design the program and the content. So first, we wanted to make the program as practical as possible, as literature reveals that coaching skills require a robust theoretical framework, but a highly practical program that's tailored to the organisation's goals. And the second thing we needed to focus on was what coaching model were we going to use? As we knew from our previous work that the participants found the coaching model being applied previously quite complex. So we wanted to simplify that. So we chose a solution-focused and strengths-based approach, which is the GROW model. Whilst there's many models available in literature, we chose the GROW model because it is quite a popular model across the world, and it was already being used in other programs within the district, such as leadership programs. So then, what did the Coaching for Better Health Outcomes program look like? Essentially, it's still become a 2 full-day workshop, but it was spaced to allow practice and reflection in between. So it wasn't 2 concurrent days, that they're spaced apart. Then within that, we have triad practice, which is groups of 3s who practice their skills amongst each other within, between and after workshops. And there's opportunities for reflection at workshops within these practice sessions and via a written submission. We've also established some community of coaching practice workshops, so we have 2 of those per year. Our online resources are available, and there's a newsletter which is sent out to all coaching alumni. So what are some of the outcomes we're achieving? We've had 118 providers trained to date through the Coaching for Better Health Outcomes program since it started in 2018. So I want to go back to the start with some of our issues. So one of the issues was that 27% agreed there was sufficient training available. That's now increased to 57% agreeing that there's sufficient training available. There was 22% who agreed there are sufficient resources and support available. This has now increased to 62%. And most importantly, previously we had 54% being able to implement and provide coaching. This has now increased up to 78%. So these numbers are well beyond our expectations even. We actually tried to aim for about a 10% increase, and even these results have blown us out of the water, really. And then quickly, I'd just like to feel some reflection. So as I said, the coaching participants provide a written reflection, and these are some of the comments that we're getting coming back to us. So I feel it has been a fantastic course, and I've benefited immensely from the structure of the 2 face-to-face days and then the 3 coaching practice sessions. Too often courses are set up such that once you walk out the door, it can be difficult to find the space and time to embed the knowledge into daily practice. Another participant said, "I feel very well supported by the coaching team. It is also made very clear that we could email and phone at any time if we had any questions or needed support. I think that is really valuable." And then an outcome from a person applying coaching. I effectively used the GROW coaching model to help a young Indigenous client manage her anxiety. The client had avoided contact with health professionals and missed multiple medical appointments. After she identified the problem, which the coaching healthcare provider assisted her to do, she was able to address the anxiety and the impact it was having on her life to develop her own solutions. After she imagined what her life would be like without anxiety, she willingly took the steps to link in with mental health nurse and went to see her GP to start on antidepressant medications. So some great outcomes. So what have we learned through this, and what are our conclusions from what the work that we've been doing over the past couple of years? So we know that the coaching is supported by healthcare providers and consumers and the literature. However, the implementation and sustainable delivery of health coaching is complex. It is influenced by many factors which are not adequately addressed by the mere provision of health coaching training, and a generic training program is insufficient to achieve widespread implementation of health coaching into practice. So reasons for this, they need to be understood within the local context, and it requires solutions to be co-designed with participants. And we recommend that significant investment should be made in planning and supporting the translation of health coaching training into practice, particularly by offering extensive post-training support and practice opportunities. And I'd like to acknowledge the project team that I've been working with throughout this for their support and being the integrated care unit and our organisational development and learning unit. Thank you.
That's fantastic. Thanks so much, Brendon. We've got about 5 minutes. We could sort of take some questions if people have any questions of Brendon. Have you answered all of the questions? Yes?
Thank you so much for the remarkable work. What sort of patient-related outcome measures are you looking at to see the impact of the health coaching program that you've implemented?
Fantastic question. At the moment, we haven't been specifically looking at patient outcomes. When we initially started this project, we actually anticipated that's what we would be doing. We anticipated we'd be focusing on quality and patient outcomes, but we realised we had a bigger problem. That was we didn't have healthcare providers actually implementing it into practice. So that's been our first step. We are continuing this work for another 3 years now. We've extended the project officer for that period of time, and we're going to start to focus a little bit more on that in the next phases of work. So hopefully we'll have some answers for that at a future conference.
Thank you. Yes. Here.
Was it made mandatory for everyone to be on the 2-day training?
No, not at all. So at this point in time, we're very much working with the willing, as in staff members from the district or local primary care who would like to upskill in health coaching. We have also, basically no, it's not mandatory at this point in time, and we are trying to work with teams though, because we found that what we're doing at the moment trialling is working with a group of people from the same clinical area or from the same unit. And we're finding that when that happens, the rates of translation and embedment into practice are improving. So from that aspect, some teams are actually making it mandatory, but we aren't. Yeah.
We've got time for one more question. I think there was a question here, and I'm sorry if you could just remember it, and we'll have it at the end.
My question probably links to the last one. It was just, that interest in, given how diverse staff are across that care continuum, acute through to outpatient community, whether you had any magical answers and you probably answered that in terms of working with them individually, but engaging. We do have the originally external provided coaching at Central Coast Local Health District, and we find the people that were originally involved in that, so largely our outpatient community and allied health services, are the ones that are more interested, or they've had some engagement for some reason, and there's some existing management support. So I guess we're probably on the same track as you, as looking for the magic reason that we can engage other services. So just if you had any thoughts.
Yeah, absolutely. So, look, I guess first of all, I don't want to say that external training programs don't work, because they could, but they need to be well supported after the training's provided. With regards to the types of the areas that people are coming from to attend training, we found that a lot of the people attending training are from community health or outpatient health, a mixture of allied health and nursing. Although we do have little pockets of people attending from other areas as well. But what we did note through our consumer engagement was, one of those quotes was, "I needed this earlier post-support." So we do need to focus more on inpatient health coaching as well. But how we can do that, we haven't actually got to that stage yet, or haven't actually found a magical answer to that, unfortunately. But the consumers do show that they want it early on in the piece. They feel like it's coming too late at the moment. So we still need to work towards achieving that.